Alright, so today we're going to discuss this chapter 67. This is your whole chapter 67. We're going to be real quick. With that being said, let's take a start. And we're going to start from swallowing. Problems related to swallowing. Alright? Those include damage to any of the nerves which control your swallowing process. And what are those nerves? Those are the cranial nerve number fifth, fifth, ninth, 10th, and 12th, right? So damage to any of those nerves can cause swallowing problem. And then you have the polio, and then you have the encephalitis. So which one of the following causes swallowing problem? Damage to any of those nerves? Polio, yes sir. Encephalitis, yes sir. Paralysis, yes sir. Okay, and then you have, this is really interesting and important point, anesthesia, right? Anesthesia. What happens is that when you anesthetize your patient, for any reason, maybe because of that drug or some irritation of the GIT, they can vomit. If they happen to vomit, all right, if they happen to vomit when they're anesthetized and you're performing surgery or anything like that, then that vomiting can lead to his or her death. How? Because when they vomit under the anesthetized conditions, the vomited stuff gets back into their trachea, all right? So it's gonna make kind of U-turn. It gets out of the esophagus and it gets back into the trachea, all right? And now the question is the trachea not blocked by epiglottis at that time? No. Why? Because under the anesthetized conditions, patient is unconscious and like the swallowing reflexes are not working under those conditions, right? And because of the lack of the swallowing reflexes, what happens is that the stuff gets out of their stomach and it returns to the trachea, and guess what? That can cause death, right? So, in anesthesia, the person can, like, there is a failure of swallowing reflexes, and that can lead to death, right? So you have to remember this. Okay, then we have the echolalia. What is echolalia? Quite simple. Everybody knows what is lower esophageal sphincter. So in echolalia, what happens is the receptive relaxation does not work. The lower esophageal sphincter is not opening. Why isn't it opening? Because of damage to the mesenteric nervous system, right? Because of damage to the mesenteric nervous system, because the lower esophageal sphincter is controlled by mesenteric nervous system. So someone asks you, what is echolalia? Yes, sir, it is actually damage to the lower esophageal sphincter, right? And why is it caused? Because of damage to the mesenteric nervous system, right? And someone can ask you, what controls the lower esophageal sphincter? It is the mesenteric nervous system. Okay, good. All right. And what happens because of this echolalia is that over years, esophagus enlarges and can hold up to 1 liter food now, and that food there can get spoiled and it can cause ulcers. All right. So now listen, what happens is that because of this constant entry of food into the esophagus and storage of food in the esophagus, like food is entering, and the lower esophageal sphincter is not opening. So what happens is that that food gathers, and because of this gathering of food, the esophagus enlarges, and because of that enlargement, its capacity reaches about 1 liter. Like it can now store up to 1 liter of the food. But as you know, esophagus is not for storage purpose; it's just for passage, right? So because of the storage, what happens is that great harm can happen to your esophagus, and it can get ulcerated and can get infected. So that's what echolalia can lead to, right? So it was quite interesting. The next thing we'll be talking about is how do you treat it? By getting a manual widener installed there, like a balloon or something like that. And uh, Also, antispasmodic drugs. Antispasmodic drugs can also help you get rid of this echolalia. So we're done with this portion, right? So we've destroyed completely this portion. Now we're going to be talking about gastritis. So let's talk about gastritis. All right. Okay. it is common in middle to latter years of adulthood. All right. So someone asks you, guy, when is the gastritis more probable to happen? Is it the childhood or what is it? So you have to remember that there is a line in the Guyton that it is common in middle to latter years of adulthood. Okay, ordinarily just superficial, not much harmful. Okay, what actually gastritis is? Gastritis is inflammation of your stomach, right? So it is the inflammation of the stomach. Okay, it says that ordinarily it's just superficial and it's not much harmful. So ordinarily, it's just superficial and it's not much harmful. All right. What does superficial mean? Is it like uh, gastritis? It's a slight inflammation of the superficial layers of the stomach. So because it's superficial, it's not that harmful, right? But all right, in long terms, it can be atrophic to your stomach mass, stomach tissue. All right. If it is chronic and it's long term, it's persistent, what it's going to lead to is that it can cause atrophic changes to your stomach, right? Okay, how are you going to treat it, right? It's treated with antibacterial drugs. Okay, now let's see what is the effect of alcohol and aspirin on the stomach. So, alcohol and aspirin, they attack the mucous glands and tight junctions of the stomach tissue. Now, first of all, let me tell you, there are two protective things, two shields in the stomach. One is the mucous glands. Of course, everybody knows what do. They secrete mucus, and that mucus causes lubrication, and also they secrete bicarbonate. So that is kind of like protective shield there, right? And the second protective mechanism there is tight junctions. Between the cells, you have tight junctions. And those tight junctions are really very tight and they don't allow any entry of any any harmful, destructive, violent thing. It is a stomach tissue, right? So those are the two uh, protective mechanisms. Now, what do alcohol and aspirin do is they can attack the mucous glands and tight junctions. And finally, guess what? They can harm your stomach tissue. All right? So, your mucosa and tight junctions. Okay. Now, in gastritis, what happens is that vicious cycle happens. All right? Vicious cycle happens. Now, it's too short here. Let me explain it to you. What happens is that in gastritis, as I told you, it is inflammation. And because of inflammation, it's usually not that harmful. But if it's severe, then what happens is that it can affect the tight junctions in the mucosa. And because of affecting this tight junction in mucosa, what happens is that the HCl is eventually going to penetrate the layers of the stomach and is going to propagate deep down into the stomach tissue and harm the structures there, right? Harm the cells there and cause atrophic changes, as I said before. So, because of that entry of the deep entry of hydrogen ions and other proteolytic enzymes into the stomach tissue, what we get is atrophic changes. And now, this is a vicious cycle, right? For example, first, a little HCl entered the stomach tissue and it harmed it. Now, this little HCl that entered is going to open doors for more and more HCl to enter, right? It's going to open doors for more and more HCl and more proteolytic enzymes to enter. And it's gonna like exponentially grow this destructive, catastrophic process. So that's why we say that gastritis, once it gets successful in destroying your stomach, then boom, guess what? It's gonna keep on destroying your stomach in a very exponential way, right? Okay. Now, what are the causes of gastritis? Someone can ask you. So it can be like kind of like alcohol and aspirin. All right, it can be alcohol and aspirin. It can be autoimmune. So autoimmune scenario, like those, like autoimmune factors can also lead to gastritis. And finally, it, as I said, it can cause atrophic changes to your stomach. Finally, it leads to loss of it leads to loss of secretions. All right, so that's what it does. All right, so we are done with this gastritis thing. All right, now the next thing we'll be talking about is it's quite simple, as the name suggests, achlorhydria and hypochlorhydria. What is achlorhydria? It is simply the failure of stomach to secrete hydrochloric acid, and is diagnosed when the pH of stomach cannot go below 6.5, right? And hypochlorhydria, as the name suggests, is diminished acid secretion. Like you still have some acid, but it's like below usual amounts, right? So that's what it is. Uh, the next thing we'll be talking about is it is sprue, right? Sprue. Okay, sprue. If you look at this line, it says that normal digestion but no absorption. It means that in sprue, digestion is normal but absorption is not normal. Like someone can trick you and they can confuse you. Which of the following is true about sprue? And then like you can just imagine such kind of MCQs, right? So digestion is normal, like you get your food digested, but it's not absorbable. You don't get it absorbed easily, all right? So that's true about sprue. Now we have two kinds of sprue. The first type is non-tropical sprue, and the second one is a tropical sprue, right? What is the non-tropical sprue? Okay, what does the tropical word means here? Tropical means like the tropical areas of the earth. So the tropical sprue stands for the sprue, like it's common in areas in the tropical zone of the earth, all right? So that's why it's called tropical sprue. Okay, what is the non-tropical sprue? It is caused by gluten. Gluten is a substance which is found in rye and wheat, right? So gluten is found in rye and wheat flours, and it can cause sprue, right? And what is sprue? It is lack of absorption. And who does absorption? Villi and microvilli, right? Villi and microvilli. So gluten causes sprue. It means gluten causes lack of absorption. It means gluten destroys villi and microvilli, right? So, sprue is caused by your gluten. The non-tropical sprue is caused by gluten. Okay, and what is gluten found? Gluten is found in wheat. Gluten is found in rye. Okay, what it does, it causes lack of absorption of food. And why it does it? What is the mechanism? It does it because it destroys villi and microvilli. So that's quite simple. Now the next one is the tropical sprue. That's found in the tropical common. It's common in tropical zones of the earth, and it's caused by some undefined bacteria. Right? Okay. What the sprue causes is malabsorption. Of course, okay, what happens is that in initial stages, sprue causes the fats malabsorption, right? Like it causes malabsorption of all the nutrients, but fats malabsorption is more dominant, right? Fats malabsorption in initial stages of sprue is more dominant. Like it's a line in Guyton. You have to remember this, right? They can ask you a question that in initial stages of sprue, which one of the following nutrients is malabsorbed? Like its malabsorption is more common. All right? Is it the fats? Is it the proteins? Is it the amino acids? Or what it is? So you have to remember this actually fats, all right? And then slowly and gradually, as the sprue gets significant place in your body, what happens is that all of the nutrients then cannot be absorbed, all right? And because of this malabsorption of fats, person can get stearia, right? Stearia. I don't remember the spellings of stearia, but according to the way I'm pronouncing it, I think it's stearia. Okay, whatever it is. But okay, we're not concerned about spellings. So, stearia, right? So, sprue can cause stearia, all right? And also, some other stuff it can do to your body is um, severe nutritional deficiency, of course, and body wasting. You're going to lose weight, all right? Of course, you're not getting enough nutrients. You're getting them digested, but you cannot absorb them. Osteomalacia, because of the calcium deficiency, inadequate blood coagulation due to lack of vitamin K, right, which is a fat soluble vitamin, and macrocytic anemia due to the lack of vitamin B12 and folic acid. So, someone can ask you which one of the following can happen in sprue. So, you have to remember that all of them can be caused by sprue. All right. Okay. So, once again, back to the line, back to the main definition of sprue. Digestion is normal, but absorption is not normal in sprue. Now we're going to see some other scenario in which absorption is normal, but digestion is not normal, right? It's kind of like you can say it's opposite to sprue, all right? And that is related to your pancreas. That is related to your pancreas, right? So what happens to pancreas when there are some problems going on with pancreas? When pancreas is in trouble, what happens is that it leads to lack of enzymes in small intestine, and then what happens is that the fats are not digested. And because they are not digested, of course, they're not going to be absorbed, because for absorption, you first need to emulsify them. So if they're not emulsified, they're not going to be easily absorbed. And if they're not easily absorbed, what is going to happen is that they're going to appear in feces, and their appearance in feces is called stearia, all right? So it is the same stearia. So someone can ask you, which of the following can cause stearia? Is it the sprue, or is it the, you know, problems to pancreas? Both of them. So both of them can cause stearia, all right? Okay, what is stearia? We have already talked about it. It is uh, fatty feces, all right? So 60% of fat is not going to be absorbed. So this is okay. Now there's a question. When I was reading myself, a question popped up in my mind that why fat? Why fat? Like, if the pancreas is in trouble, why is the absorption of fat mainly affected? Why not proteins? Why not carbohydrates? Yeah, they're also affected, but why fat mainly? The reason for that is the pancreatic lipase is the major fat digesting enzyme, while if you look at proteins and carbohydrates, they have a lot of backup systems, right? Other other enzymes can spare them. Stomach also give you a great deal of proteolytic enzymes, and also in saliva you have they have backup systems available, but fats mainly depend on your pancreatic lipase, right? So that's the reason. Okay, so it can bring into existence stearia. You have to remember this. Okay, next topic, that is the constipation. Definition of constipation: it is the accumulation of feces in the descending colon. Where? Descending colon. Okay, constipation is accumulation of feces, and what's the following? It's mainly in the descending colon, right? Okay, why does it happen? Now, it is really a beautiful point. Like, someone can confuse you. Which of the following is the cause of constipation? Is it the excess absorption of fluid or insufficient fluid intake? Is it the excess absorption of fluid or insufficient fluid intake, or both of them? both of them, right? So either excess absorption of fluid or insufficient uptake of fluid, both of them can lead to constipation, right? So those are the causes of constipation. Okay. Also, we say that a pathology that obstructs movement of intestinal contents, like tumors and adhesions and ulcers, can also cause constipation. Of course, like for example, the intestinal content wants to go down the colon, it, it want to travel down the colon, but there is a tumor in the way, right? And that tumor is not letting it pass, all right? And because that tumor does not let it pass, what happens is that the intestinal content is going to stay there for longer periods of time, and fluid is going to be reabsorbed, because large intestine is mainly concerned about fluid reabsorption, and because of that excess reabsorption of fluid from your uh, intestinal content, that's going to cause constipation eventually, right? So, which one of the following is a reason of constipation? Is it the excess absorption of fluid from the intestinal content? Yes, sir. Is it the insufficient fluid intake? Yes, sir. Is it the pathology that obstructs the movement of intestinal contents? Yes, sir. All of them, right? So that was about the constipation. Now, now, all right. Now we're gonna be talking about enteritis. We're gonna be talking about diarrhea, right? This portion is dedicated towards explaining diarrhea. Okay, let's talk about diarrhea. Diarrhea. Now we're gonna be uh, we're gonna be breaking down different things, different reasons of diarrhea, right? First, we're gonna start with enteritis. Enteritis. As the name suggests, enteritis is inflammation of your colon, right? And the enteritis is caused by bacteria or viruses, right? And to get rid of those culprits, to get rid of those bacteria or virus or fungus or whatever it is that is causing your enteritis, to get rid of them, what body does is that it secretes excessive amount of mucus, right? It secretes a lot of content, all right? So what happens is that because of that over secretion, uh, the enteritis ends up in diarrhea, right? Like, for example, if there is a lot of mucus, in order to get rid of those inflammation causing uh, culprits, the bacteria or viruses or whatever it is, body secretes a lot of mucus, and because of that lot of mucus, the person gets diarrhea. All right? So that's how enteritis can lead to diarrhea. Then you have the psychotic diarrhea. Psychotic diarrhea. As the name suggests, it's quite simple, and you might have experienced it in your daily life, somewhere in your childhood, during your examinations, the prof exams, maybe, right? So, in short, the psychotic diarrhea is caused by excessive stress. When person is stressed, what happens is that there is overstimulation of parasympathetic activity, right? The parasympathetic activity gets intensified and enhanced. And what happens is that because of this increased parasympathetic activity, the colon movement increase, and because of this increased colon movement, the mucus secretion increase. No. What happens is that the colon movement increase, and at the same time the mucus secretion also increases, and because of both of those things, diarrhea happens. Number one, because the intestinal content is moving too fast, so it does not get enough time to get its fluid absorbed by the large intestine, and the second, because of a lot of mucus, we get diarrhea. Beautiful. So that was the psychotic diarrhea. It's quite simple. Now, the next thing is cholera. Everybody knows cholera toxins, all right? they can cause diarrhea. And why do they do so? Because those toxins can stimulate your crypts of labor coons to secrete a lot of mucus, right? So cholera toxins stimulate your crypts of labor coons to secrete excessive mucus, and because of that excessive mucus secretion, like what happens is that 10 to 12 liters of fluid daily it is secreted. That's too much. And because of this 10 to 12 liters of fluid that is getting secreted every day because of the cholera toxin, person ends up getting diarrhea, right? And also it causes the loss of like a lot of electrolytes from the body. Like it destroys the whole osmolarity of extracellular fluids, and that can eventually lead to death, right? So it's not something easy. It's really destructive. Cholera can cause excessive fluid loss. That is 10 to 12 liters per day. And the normal absorptive capacity of large intestine is just 8 liters. And we're getting 10 to 12 liters lost. And that's, of course, going to cause death, right? So, now we're done with diarrhea. We okay, now wait a minute. There is another thing. That is all right. Ulcerative colitis. That is another cause of diarrhea. What happens is that inflamed and ulcerated. The colon gets inflamed and ulcerated, right? And it can increase motility and secretions. Why? Because it wants to, like the colon wants to protect its tissue, and it wants to stop the growth of those ulcers. So what it does, it secretes a lot of mucus, right, in order to protect itself. So because of that over secretion of mucus and increased motility, um, person can get diarrhea, right? So that is also a cause of diarrhea. What is its cause? What is the cause of ulcerative colitis, right? This inflammation. It is hereditary, and the cause is like unknown, right? So um, it can lead to unhealing ulcers, right? Like common, sorry, like persistent ulcers. All right, person is suffering from ulcers which cannot be healed. Right, that is like how his. It's not something coming from outside and causing it. It's just like how that person is born. He or she is born with this condition, right? He or she's getting like unhealing ulcers on daily basis, he or she is getting unhealing ulcers, and that needs ileum removal or maybe the whole colon, right? So it's like something serious. So someone can ask you questions from ulcerative colitis. What is this? It's inflamed and ulcerated colon. It can cause diarrhea, right? And it is unhealing ulcers, and it needs ileum removal or maybe the whole colon removal. All right. So that was about the diarrhea. So we talked about constipation and the different things related to constipation here. All right. We talked about the reasons of constipation. Okay. Then we talked about diarrhea and the different scenarios leading to diarrhea. First of all, we talked about enteritis, then we talked about psychotic diarrhea, and then we discussed the cholera, and then we talked about the ulcerative colitis, and now we're going to be discussing this black portion, which is a hybrid of diarrhea and constipation, right? So it's kind of like you can say a hybrid of diarrhea and constipation. So let's talk about it. What is this? Like, imagine a person who ignores defecation on daily basis. All right, they're like, okay, there is a defecation reflex happening in the body, and they're like, "Oh, I'm okay. I'm okay. I don't want to go to the washroom." They're just too lazy to go to the washroom, right? And they want to go to the washroom, and they're ignoring it. What happens is they are harming themselves. In the moment, that might sound cool, but they're actually harming themselves, right? They're gonna get a tonic gut, right? That kind of person is gonna get a tonic gut, right? What is a tonic gut? Is that the because of this constant ignorance, their colon loses great percentage of its motile capability, and that's gonna lead to a tonic gut. And also, there is another reason that can cause decrease in the motility of the gut. That is oral use of laxatives. What are the laxatives? These laxatives are drugs which helps people to deficit. But if someone is constantly dependent on those kind of drugs, they're gonna get less motile gut at the end, right? And then we have spasms. Okay, so if the gut is less motile, guess what? That's gonna cause constipation. All right. So someone can ask you, which of the following can cause constipation? Ignoring defecation, yes sir. Or use of laxatives, yes sir. Because both of them cause atonic gut, and atonic gut eventually cause constipation. Also, spasm, right? Also, spasm can cause constipation. So spasm can also cause constipation. Like, for example, there is a spasm of smooth muscle somewhere in the colon that can lead to constipation, right? Okay. Now, what happens is because of that constipation, this constipation is followed by over secretion of mucus, right? In order to get rid of it. Like the colon is trying to get rid of the constipation, and in order to get rid of it, it secretes a lot of mucus, and because that's over secretion of mucus, guess what? The diarrhea is gonna happen, and it's gonna end up in diarrhea, and then that diarrhea is again going to be followed by constipation. Why? Because of those reasons. The person is still taking laxatives, he is still ignoring defecation, and maybe there is still, because of some reason, spasm. Then diarrhea happened because of constipation. Diarrhea happened, and now after this diarrhea, because those reasons are still here, again the constipation is going to happen, and then again diarrhea, and then again constipation, and then again diarrhea, and then constipation. It's going to keep on rolling like this, right? So it's a like kind of unique scenario where the diarrhea follows constipation, and then again you get the constipation, then diarrhea, and then constipation, then diarrhea, and it's just keep on rolling like this. So this is how it works, right? So we're done with diarrhea. We're done with the we're done with the. I'm so sleepy, right? So we're done with diarrhea. We're done with constipation, and now let's see what's next. Okay, so we have a little portion of this chapter remaining. All right, real quick. Now let's talk about vomiting. Vomiting. Okay. What is the zone for stimulation of vomiting? It can be like caused by irritation anywhere from pharynx to duodenum, all right? Like duodenum distension is a more intense cause of it, right? So that means that vomiting can be triggered by irritation anywhere from pharynx to duodenum, by irritation anywhere from pharynx to duodenum. But distension of duodenum, that is more intense stimulus for causing vomiting, right? So that's it. Now, what are the afferent nerves the carrying nerves, the sensory nerves for those stimuli for vomiting. Those are your vagal nerves and the sympathetic nerves, right? So vagal nerve and sympathetic nerves. So someone asks you, you have to memorize this, right? The vagal nerve and the sympathetic nerve. Those are the afferent fibers for vomiting. And the next thing we're going to be talking about is efferent fibers, right? What are the efferent fibers causing vomiting? Actually, you have to remember this thing. The we see that means vomiting center. The vomiting center is located in the brain, and it gives efferent fibers, right? So they originate from the vomiting center, which is in the brain. And what are the efferent fibers? Efferent fibers to different portions of the GIT are different. Like in upper GIT, the efferent fibers for vomiting are those nerves, the cranial nerve 5, 7th, 9th, 10th, and 12th. Like the same nerves, almost the same nerves which cause your swallowing, which are involved in your swallowing, they are also involved in the vomiting in the upper GIT, right? Now, if you look at the lower GIT, in the lower GIT, it is again the vagal nerve and the sympathetic, right? The vagal and sympathetic in the lower GIT, right? Just like the afferent one, right? So, if someone asks you in the upper GIT, those nerves. In the lower GIT, it is the vagal and sympathetics. And also, the diaphragm and abdominal muscles are also involved in vomiting. So, the signals to them are directly coming from spinal nerves, right? Spinal nerves. Those are not the cranial nerves, right? Those are not cranial nerves. Those are spinal nerves. So that was about the afferent and the efferent and the zones where vomiting can be triggered. So that was about vomiting. Was quite simple information. Now we're going to be talking about mechanism of vomiting. Everybody knows vomiting is caused by reverse peristalsis. It starts down in the ileum. Like that's how deep it can start, right? Like vomiting can start deep down in the ileum, and from ileum it can go like the reverse peristalsis can proceed upwards at with a speed of 2 to 3 centimeter per second, right? Like it starts in the ileum and then it gets in the jejunum, then the waves get in the duodenum, and then gets in the stomach and then the esophagus, and then finally, boom, vomit. All right, so that's how it can be happening. Okay, now let's talk about some causes of vomiting. There's some three main causes of vomiting. All right, vomiting can be triggered by some drugs. How? Right? How do those drugs cause vomiting? Now, the answer to the question is that there is actually a center in there is an area in the fourth ventricle of the brain. There is an area that is chemoreceptive area, right? That area is chemoreceptive. And when you take morphine or drugs like that, those drugs can stimulate this chemoreceptive area, and this can then cause vomiting. All right, this can then cause vomiting. Now, if this area is damaged, it can cause drugs to not affect vomiting, right? If this area is damaged or removed, then no matter what quantity of drug you take, that's not going to cause vomiting, right? So this is one of the causes of vomiting is that you take drug. Those drugs are in turn going to act on that area in the fourth ventricle of your brain, and then that area in the fourth ventricle brain, that's eventually going to cause the vomiting signals to travel into your GIT. If you remove this area, then no vomiting is going to be caused by drugs. All right. Now the second cause is motion sickness pathway. Everybody is familiar with this one. When, for example, you're in motion ride or in some fast moving vehicle or whatever it is, that can end up giving you vomiting. How does it happen? Is that motion sickness pathway, and it starts in the vestibular labyrinth, then it goes to the vestibular nuclei, then to the cerebellum, that is the body balance center, and then to the chemoreceptor trigger zone, the same zone, this one, right? This one. All right. So this motion sickness pathway and drugs, both of them are actually dependent on this chemoreceptor trigger zone, right? This chemoreceptive area in the fourth ventricle. So when you're moving too fast in some vehicle or maybe some ride or whatever it is, the vestibular labyrinth sends signal to the vestibular nuclei, and then from the vestibular nuclei, the signals go to the cerebellum, and then from the cerebellum, they enter the chemoreceptor trigger zone, and then, same like this, what happens is that this zone sends signal to the vomiting center, the VC, here, and then from the VC, what happens is that the signal go to the GIT, and then it causes vomiting, right? So that's how it works. So, like, both of those, like the drugs causing vomiting, and this motion causing vomiting, both of them are dependent on this area. All right. So if you remove this area, those two things are not going to be working anymore to cause vomiting. All right. Now let's talk about the third cause of the vomiting, and then our chapter is almost closed. It's completed. You have the gastrointestinal obstruction. Gastrointestinal obstruction can also cause vomiting. How? Let's talk about it. The gastrointestinal tract can become obstructed at almost any point. Common causes include cancer, fibrotic constriction, from ulceration or adhesion, spasm or paralysis. All right. So those are this is a list of reasons. All right, for gastrointestinal obstruction. Now, let's talk about obstruction at pylorus. Now, there are some important MCQ points here. We're going to be focusing on it, right? Obstruction at the pylorus. It is persistent vomiting of stomach contents. Persistent vomiting of stomach contents. What happens is that when the obstruction is at the pylorus, the content in the stomach is not going to pass into duodenum. So guess what? What it's going to do is going to try to get out of the body and it's going to climb up because it has no way to go down the duodenum. So it has only option left to travel back up, right? So what it does is that you're going to vomit the stomach content, and as you know, that the stomach content has a lot of hydrogens in it, right? It has a lot of hydrogen ions in it, so it's going to cause loss of a lot of acid, and because of this loss of acid, the person is going to get alkalosis, right? Alkalosis and also malnutrition, of course, all right? So if someone asks you that the obstruction at which one of the following points can cause alkalosis, is the obstruction at pylorus, or obstruction beyond the stomach, or obstruction near the distal and the large intestine, so have to remember there's actually obstruction at the pylorus that can give you alkalosis. Now the next thing is obstruction beyond the stomach. Let's talk about the obstruction beyond the stomach. What happens? When there is obstruction beyond the stomach, let's say obstruction right next to duodenum. Let's imagine that, right? There is obstruction right next to your duodenum. What will happen is that intestinal juices will reflux back into stomach and they will be vomited, right? And because of that, there is going to be severe loss of water and electrolytes, all right? Acid and bases lose roughly. Acid and base losses roughly balance. All right, so I actually stopped the lecture mid because my roommate was back from his home, so I don't know where we were. Oh, okay. So acid and base losses roughly balance. Now, what does it mean? Because stomach is mainly acidic zone, right? Everybody knows that stomach is mainly acidic, right? Its secretions are acidic. And if you look at the intestine is getting secretions from pancreas, and also like it itself releases bicarbonate and mucus. So that is mainly basic, right? Now there is going to be a balance, because if the obstruction is beyond the stomach, what's going to happen if the obstruction is beyond the stomach? Because of this obstruction beyond stomach, we are mainly going to get both the intestinal and stomach contents lost. And it's a combination of acidic and basic content. So at the end, what happens is that the acid and base losses balance each other, and there is no net loss of acid or base, right? So it remains relatively normal. So the classic MCQ one, someone can ask you, and which in the following alkalosis happen? It is in the obstruction at the pylorus, and which in the following the balance stays? It is beyond the stomach. Now we have the obstruction near the distal end of large intestine. Now let's talk about obstruction near the distal end of large intestine. Feces accumulate for a week or more. Vomiting is mild at first, then becomes severe. Then it becomes severe when the colon is completely full. When the colon is completely full, right? Prolonged obstruction can lead to rupture or dehydration and circulatory shock. Wait a minute. Let's talk about it. It says that feces accumulate for a week or more, and the vomiting is mild at first, and then it becomes severe when the colon is completely full. And prolonged obstruction can lead to rupture or dehydration and circulatory shock. So, okay, this one was a little bit complicated. It says that when there is obstruction down there in the large intestine, what's going to happen is that fluid is going to accumulate. It's going to accumulate in the large intestine, and the vomiting is going to increase accordingly, right? And because of that increase in vomiting, severe dehydration can happen, and because of that dehydration, you can get a circulatory shock, right? So someone can ask you many different questions, like related to alkalosis. Then you have the acid-base balance is the acid-base balance is not disturbed in which one of the following, and which one of the following can lead to circulatory shock. All right, so we're done with vomiting, right? To sum up what we talked about it, we talked about the afferent signals, then we talked about the efferent ones, this, and then we talked about its two causes, which were related to the chemoreceptor trigger zone, and then we discussed this third one, which is related to obstruction. So it's within itself is a separate topic. So we talked about those three kind of scenarios, right? The three kinds of obstruction there. Now we're gonna be talking about nausea. What is nausea? Nausea is just a consciously feeling the unconscious desire to vomit. Sorry, I should say consciously feeling the subconscious, consciously feeling the subconscious desire to vomit. So that's what we call nausea, right? Okay, it can be caused by irritative impulses from your GIT. It can be caused by motion sickness, right here. And also, it can be caused by signals from the cerebral cortex. What does that mean? Like, for example, you saw something that is disgusting to you, you smelled something that is disgusting, disturbing. So all those things can cause nausea. And so that's about nausea. And nausea can lead to vomiting, right? But there is a misconception. A lot of people think that it's necessary that first person has to get nausea and then he or she will vomit. No. Nausea is not necessary. A person can vomit without nausea, right? Vomiting can occasionally occur without preceding nausea. And that's why sometimes people vomit, but that's not that disturbing because there is no nausea involved. But the vomiting, which is associated with nausea, it's really disturbing. You must have experienced it in your uh, real life, and if you have not, you're lucky enough. So, so that was about the chapter 67. I was a bit dizzy, a bit sleepy. So, but still, I tried to deliver it. Thank you very much. Take care.